Good morning. So, from our research in this framework, we found that those 6 elements were important for successfully leading quality, safety, reliability in an organization, in a department, in a group. But we found and I think we probably all know this intuitively, even if we were patient-centered and did everything right for capability and vision and engaged across boundaries, if we didn't have the culture right, nothing's going to happen with the best projects, the best Lean Sigma engineers. So that's the domain, the shaping culture of this leadership framework that I'd like to discuss this morning. About 2 years ago, I had a chance to meet Eric Kropp in Ohio at Cleveland. Eric was an excellent, competent, conscientious, hardworking pharmacist involved in a tragic error. His assistant, his pharmacy assistant on this day, mixed up a saline solution that was the carrier for a chemotherapy agent for a young toddler, and she mixed it up tenfold too high, resulting in the death of the child. And it was, extraordinarily sad, unfortunate situation. It was tragedy. It was a medical error that could have happened to any of us in this room if we were doing that work. They followed every protocol. They did not work around any policies. They were competent. They weren't impaired with sleep or drugs. So how should the state of Ohio treated Eric Kropp? In a fair and just culture, Eric Kropp would have been consoled, and his assistant would have been consoled, and the leaders of the organization with the industrial engineers would have come in and say, what can we do to make sure this never happens again with safety nets and rechecks and information technology, whatever it would take. Well, instead, what the state of Ohio did was they took away his license and they put him in jail for a human factors error that any of us could commit. In fact, the most competent professionals, or truck drivers, or lawyers, or radiologists, have a 1 to 3% error rate doing repetitive tasks at which they are extraordinarily competent. That's the nature of being human beings. So the nature of safety in healthcare is to understand that and have safety nets and rechecks and protocols in place that understand the frailties of human beings. So that's the first part of a fair and just culture, is to treat individuals appropriately for medical errors. Now, there's a difference, an important distinction between medical errors, risk-taking behavior, and reckless behavior. And to understand that, we first have to understand what is competence. So by all measures, Eric Kropp and his assistant were competent. But we can't judge a medical error unless we have a level of performance that we expect. Anybody know who that is? Yeah, that's Steve Nash. At least last time I checked, he had the highest percent of free throw success, 90.048% ever in the NBA. And it's about 8 or 9 professional basketball players every year that shoot around 90% from the line. So the vast majority of NBA players don't get even 90% from an unobstructed shot. So what's the level of competence for an NBA player? What's the level of competence for a mammographer with detection and recalls and biopsy rates? What's the infection rate that's a level of competence for interventional radiologist, et cetera, et cetera. So for each of those, we have to define what is an acceptable level of practice, and then and only then can we decide as a group or department or institution what is a medical error versus what is risk-taking and so on. So then the next step of risk-taking is when you'd move beyond a protocol or work around some established norm. So who's the better tennis player, Serena Williams or Venus Williams? Yeah, Serena. She's the second-born. Second-born children are better athletes than first-born athletes. I like this because I was second-born. So there's a really interesting study in the Social Psychology Review that looked at 700 professional baseball player siblings. And it turns out the second-born in that series of 700 professional baseball players were 10.6 times more likely to steal second base than their older brothers. And they were several times more likely to get in the way of a 90-mile-an-hour pitch to get a free base on balls. They were risk takers, and that's one of the reasons that the second-born children are better athletes and more successful at the highest levels. So in healthcare, we don't want to hire the second-borns. We want the first-borns. What we want are colleagues that look at the protocols and follow the protocols. They don't work around a standard of care for convenience or because they want to. They don't take risks unless you're in an emergency kind of situation. So the risk-taking behavior is one that we coach. So if someone for the first time maybe decides that they don't need to follow the bundle for central line placement or for anticoagulation or for a pre-interventional procedure briefing, then you sit down with them and say, look, there's a reason for this policy. Our memories aren't as good as our patients need without a checklist, et cetera. That's a risk-taking behavior workaround policy. If they do it again, that's reckless behavior that needs a different kind of action. It's a corrective action, a performance management discussion. Sometimes it means you fire them, but it's a progressive look at it. So the general approach to near misses and harmful events is to first ask the question, was it the system? And then was it a faulty design or a lack of a system or a poor protocol? And then you fix the protocol or you fix the process or the system so that we continually attempt to design the most reliable systems and processes of care for our patients. Then the second question, and this is all done without regard to whether the patient died or was harmed, is in a fair and just culture, that's irrelevant. What's relevant is, did we follow the protocols? Is the person competent? Did we exhibit reckless behavior, or was it a human factors error? So the second question then, after was it a system, is was it the behavior? And then you go to that trichotomy of human error, risky behavior, and reckless behavior. So that's this piece. And so to review, in a fair and just culture, if it is an inadvertent action, a lapse, a split, a mistake in a competent individual who is not compromised by other issues, then you console that individual. You look to learn and improve the system of care. If it's risky behavior, where you've worked around an existing protocol or safety net, then you coach. And if it's reckless behavior, where you say, I'm not doing this pre-op checklist because it's insulting to me or my memory's too good, then it's a performance management on the way to firing that individual. And institutions need bright lines about what is acceptable and what's not acceptable, and that would certainly be one that we would have for following those protocols. The protocols we have for central line anticoagulation, the whole bit, we encourage physicians to opt out of them. We encourage physicians to opt out of them for patient-centered reasons, and we just ask them to tell us why, so we can make the protocol better. Most of the protocols work for 70 to 80% of patients, and about 20 to 30% of the time they don't, because the protocol either needs fixing or because you got a complex patient with diabetes, heart failure, and rheumatoid arthritis on 7 medications. So, but we insist, after encouraging the opting out, we insist that we can learn from the situation so we can make the protocol better. First, the central line bundle and maintenance, that works like 98% of the time. But there's some trauma situations where you can't put a central line in the chest, and you do the groin, and then you move it from the groin to the chest when they're in the ICU in a safe environment. At Mayo, if you breach confidentiality, if you're looking at a medical record that you don't have access to or don't have a reason to be looking at, we just fire you. That's reckless behavior. It's a bright line. We don't ask questions. Security comes in, walks you out, and you're done. So that's the trichotomy of fair and just culture. If everyone knows that up front, then we can move forward and in a proper way. We do this in part to treat colleagues fairly, but we also do it to encourage the reporting of events, near misses, harmful events, so that we can learn. So Eric's crop replacement, how likely do you think he is to report a medical error or a medication error to his or her boss? You shut people down. So part of the justification or the rationale behind a fair and just culture, beyond treating people fairly, is to encourage the reporting of events and near misses so that you can learn and continually improve your organization and your safety and your reliability. So that's fair and just culture. There's several other attributes of a safe culture that and transparency that are worth looking at, and I'll go through a few of them. So in 1950, Gallup surveyed graduating high school seniors and asked the question, are you a very important person? In 1950, 12% of high school seniors said, yes, I'm a very important person. So they repeated the survey 48 years later in 1998, asked the same question, are you a very important person? What percent of high school seniors said yes in 1998? 80%. So 12% to 80%. So it's kind of an interesting survey, but I put it in here to bring up the organizational attribute of humility. If our leaders, if our professionals, if all of our staff isn't humble in the approach to the opportunities for improvement, you aren't going to improve. If you think you're the best, if you think that you can't get better, then you won't. And humility is a critical ingredient for continuous improvement. And that attitude of, well, I could be better, and I'm always looking for those opportunities. So what single thing can you do to a cow? I'm a Midwest boy. This is actually peer-reviewed research from Newcastle in the United Kingdom. What single thing can you do to a cow to increase her milk productivity by 62 gallons a year? Give her a name. So in Newcastle, they gave their cows names, they treated them with respect, and their milk productivity went up 62. I converted the liters to gallons, 240 liters of milk a year. Well, the same thing happens with human beings. If you treat them with respect, if you know their names, their productivity goes up. You know, it's related to that discretionary effort and the engagement, but patient satisfaction goes up, and they're more productive and appropriate members of the integrated multidisciplinary teams. So it plays to the area of psychological safety. What percent of nurses in this country, in repeated surveys of nurses in this country, would say they would not speak up if they saw a patient about to be harmed? Year after year, that number is 35 to 40% of nurses say they would not speak up if they saw a patient about to be harmed, because they don't feel psychologically safe. And that's usually because the physician or physicians with whom they work have created an environment of this power distance index between each other where they're not comfortable in raising their hand or saying, you may have the wrong fluid there, or is that the right patient, or is that the right side? And so our obligation as leaders of multidisciplinary teams is to create a safe environment for speaking up. If you look at the causes of preventable harm in this country, the Joint Commission, just over half of them are related to communication and handoffs. They're related to interhuman issues of comfort with each other. And they aren't technology, they aren't the medical errors like your crops, they are interpersonal issues. And the more that we can do to make ourselves comfortable as a team, the lower our medical error rate will be. And that's a fundamental of safe practices. If you look at the commercial aviation sector, we are dramatically safer than 30 years ago flying on a commercial jet. And when you read the research from the aviation specialists, there have been some mild, minor, incremental changes in technology that made a difference. But the difference and the reason that we're so much safer in commercial airways today is because of what's happened in the cockpit between human beings. So with crew resource management, the captain is now better able to listen to and use all of the collective information and knowledge and observations of the first officer, the navigator, the air traffic control, the ground crew. And 30 years ago, we were crashing a whole lot more planes because the captains weren't able to do that. Same thing happens in the operating room, same thing happens in multidisciplinary rounds in the hospital. And so the 62 gallons of milk deal is a big deal for patient safety. Transparency. So President Clinton's heart attack, was that 8-9 years ago now? He was fortunate that he was able to undergo elective coronary artery bypass surgery as part of the treatment for that heart attack. He chose to have that heart attack in New York City at Columbia Hospital. And turns out he made the wrong choice. Columbia Hospital had a 2.5 times higher risk-adjusted mortality rate than Cornell, and the highest risk-adjusted mortality rate of any hospital in New York City that was doing elective coronary artery bypass surgery at the time. And all that information was available 5 mouse clicks away on the internet. Mark Chasson, the current president of the Joint Commission, was then the state commissioner of health in New York, and several years earlier had put that all onto the internet so that patients could choose to go to the safest hospitals or the riskiest ones. And I told the story at a World Healthcare Congress a couple years ago, and a physician from Columbia came up to talk to me. Anybody from Columbia here? And he said, you got that right, those are the numbers. But what you got wrong was it wasn't President Clinton who chose the high-risk hospital, it was Hillary that chose the high-risk. Transparency is an amazing tool that all of us can use in our groups, in our institutions, in our departments. And in the state of New York, what happened, once Chasson released that information on the internet, what happened to mortality rates in the New York hospitals? They plummeted 41%. And a decade later, they're still 41% lower than they were before those results were transparent. Well, it wasn't patients that accessed that and started changing their choices and going to safer hospitals, which you'd think they might for elective procedures. It was actually just the doctors and the hospital administrators that looked at that and said, holy smoke, we're not as good as we thought we were, and they either got better or they stopped doing cardiac surgery, and it lowered the risk-adjusted mortality rate by 41% in the state. So on a statewide, a nationwide basis, transparency is a powerful tool. It's probably one of the most powerful things that we can do in our individual groups and departments is showing folks their results. I've never, in my years involved in this work, met a physician or a group of physicians who wasn't surprised to see that their actual performance wasn't as good as they thought their performance was. So what happened in 1967 in Sweden that lowered the traffic fatality rates by 17%? They switched from driving on the left side of the road to driving on the right side of the road, and that lowered traffic fatality rates by 17%. Why would it lower accident rates? One of the characteristics of a high reliability organization, according to the research of Sutcliffe and Wyke at the University of Michigan, is employees at the nuclear power plants or the naval aviation aircraft carriers are looking for things that could go wrong. When the Swedes came up to an intersection, they were looking for something that could go wrong because they knew that people might be more likely to turn the wrong way or get in the wrong lane. And that lasted about 3 years, and then it came back up to where it was before because people got comfortable with it. That's the purpose of transparency, is to constantly remind us that sometimes we get infections if we don't do hand hygiene. Sometimes we have complications to central lines. Sometimes we have a high readmission rate, and you aren't aware of it unless you actually see the poster in the hallway or the internet posting, or it's part of your annual performance review with your chair or your boss or your manager. And that's part of a culture of safety, is to have people constantly thinking about this, because you can't do FMEAs and safety net processes for every thing that we do. You have to have the human awareness and caution of going into procedure. That's what the timeouts are for and the checklists are for. So in the first Gulf War, we had these F-15 Eagles with $4.6 million lantern imagers attached to them. And these lantern imagers were amazing cameras that helped us see these Saddam Hussein's Scud missile launchers. And so we destroyed these Scud missile launchers, over 100 of them, with these lantern imagers on the F-15 Eagles. After the conflict, we went in to check on the ground to see how many of those Scud missile launchers that we destroyed, that we actually destroyed. We thought it was over 100. How many do you think we actually destroyed when we checked on the ground and actually measured our results? 0. Not one. They were all there. Missed them all. And so this is what the measurement piece is. We've got to measure anything that's important to us, anything that's important to our referring providers, anything that's important to, most important, our patients and families and communities. And whether it's satisfaction, whether it's the number of glomeruli in a renal biopsy for rejection, whatever it is that's important, we've got to measure it. And if it's not to the level that we would aspire to as a patient or provider or for any of our customers, then that's our work for the next weeks and months ahead. Measurement is a fundamental of a culture of safety and transparency. We measure every death at Mayo Clinic. We have about 40 a week at our 24 hospitals. Most of those are anticipated deaths, but we go through all of them in a templated way to look for systems issues. And this is not a backroom function of a bunch of quality officers. These are frontline doctors, nurses, pharmacists, administrators that are looking for systems issues. And these systems issues then allow us, so what can we focus on next week and next month to keep the death rate going down? And so we're not looking for punitive action or causality. We're just looking for issues. And it's been a very rich cultural a rich database and a very powerful cultural discussion to go over each of these deaths one at a time with frontline folks. Do the same thing for preventable harm. Any harm event any serious harm event at Mayo, we measure, we discuss for the front line. Was there a protocol in place or a guideline or a safety net, and did we follow it? And was the protocol world class? And then if it was world class, it was in place, couldn't improve on it by today's science, and we didn't follow it, then that was a preventable death or preventable harm event. And these are frontline discussions, so people understand the importance of having the best possible guidelines and protocols in place and of using them, not working around them. And then that helps us continually move our risk-adjusted mortality rate so that the observed deaths are 40 to 50% lower than expected. And the only way you push that line down is if you look at systems issues and processes and continually and relentlessly repair them. And then finally, I'm down to a few seconds here, is diffusing the best practice. How long did it take American physicians to give beta blockers to heart attack patients? In the early 80s, there was a randomized controlled trial. We stopped it early because there was such a huge death benefit to giving beta blockers to heart attack patients. It took us 25 years and 6 weeks for 90% of American patients to get a beta blocker. So there are national issues with diffusion and departmental issues and organizational issues, and we, through our Mayo Clinic model of fusion, for anything that we think is important, like our central line bundle, we have a process to identify the best practice and diffuse it to every door at Mayo Clinic and keep that in place so that the culture of our organization is one that expects opportunities to improve and looks for the sharing of the best practices across our presence. That's a look at the shaping culture piece of the framework. If you don't have culture right, the best projects in the world are going to fail. Thank you.